This is a mindfulness science keynote from the USC Center for Mindfulness Science. We're very glad you can join us today. Dr. Tang is originally from China, where he's both, if I remember correctly, a family medicine physician as well as a neuroscientist, and largely, again, if I'm remembering correctly, based on his own internal benefits from mindfulness and the benefits he was seeing when he would teach his patients these practices for their general health and well-being. He became interested to understand what's going on in the brain to allow for these benefits to occur, and came to America and started a series of studies with Dr. Michael Posner at the University of Oregon, and then on his own as a professor at Texas Tech University now for these last few years. And I'll just say that, you know, his work has been very impactful to the field. He's published quite a number of very high impact papers demonstrating some of the key neural mechanisms that seem to get going in the early stages of learning mindfulness. And so we're just very happy to have Dr. Tang with us, and it looks like George has now made you a co-host, so you should be able to bring up your PowerPoint now. So without further ado, Dr. Tang, thank you so much.
Okay, thank you for introduction. Let me do this one right now. Okay, hold on. Oh, 1 minute.
We can see that.
Yeah, hold on. Let me do that one again. Forgotten this one. Advanced portion.
And maybe I'll just say one other housekeeping matter, which is that we will host the talk for approximately an hour or so, but we will have time for question and answer after until 1:30. So if you have questions along the way, feel free to enter them either in the chat or the Q&A boxes, which you can find at the bottom of your screen. If you hover over the bottom, you'll see chat, Q&A, and we will keep track of those and pass them along so that Dr. Tang can address any questions and further areas of discussion.
Thank you. I think you can see it okay, right?
We can see it.
Okay. So in that situation, I can move on. So this is a focus. So today I'm going to focus on the short-term effects, mainly based on the RCT design, randomized control trial. Then the targeted mechanism based on the self-control. Then after that, as a future direction is our discussion time. So usually when we study the brain, the body, and the healthy behavior, so we have a lot of neuroscience tools. So we can use the imaging. Okay, I use a laser today. Okay, so we can use the imaging, target the whole brain, target one system or certain network. So we can check behavior, disease, and therapy intervention that go to the lifespan. So today I'm going to use imaging, behavior, and some physiology matters. In general, we all know mindfulness means, right? Then actually, there are so many definitions. In particular, there remain no single correct version of mindfulness, just people have a different idea. However, we can say it's a state, it's a trait, it's a process. So how about the compassion? So awareness is shared with mindfulness. Someone suffering, then being moved by it and acting. So it means there is some action involved. So certainly, compassion also consists of noticing, feeling, responding. And compassion also involves the distress tolerance and the non-judgment. We can see the shared process. But in the literature, a multi-dimensional process involved. It's complicated. So then we look at both mindfulness, compassion-based practice, so people can say all this part to define. Now, mindfulness training have been shown to increase real-life compassionate behavior and necessary for the cultivating compassion. It seems that mindfulness could be a fundamental step. Then mindfulness compassion share the common process. This is what I'm going to discuss today. Although the controversy exists, we all know, but I want to make the point. The key actually is the mental process involved in the practice. It doesn't matter. It doesn't matter about the concept, the name, the definition. In other words, the direct experience participants have so important. So my research actually focuses on the mindfulness intervention and the shared process critical for the fasting compassion. So I want to share with you one short example. It's an experience. It's really, really funny, but you just follow me. Then you will find it's fun. So we are going to do the add these numbers do together. Very simple. Like if 1,000 show up, then you follow me to say 1,000. Just follow me. Then you will see the 40. Then you add them together. So you will report 1,000, then 1,040. Then another, you will say add together 2,040. Then another one, then 2,070. Just follow me. Add a number and read together. So if you're ready, so we can try. Okay, so we are ready. So 1,000, follow me. 1,040, 2,040, 2,070, 3,070, 3,090, 4,090, 5,000. No. 5,000 or 4,100. You should be aware, majority of us report 5,000, but the real answer is 4,100. So what happened? So in daily life, it happened a lot. So actually the mindfulness help noticing new things, noticing put us in the present. So this is a little bit different. So when we are mindless, we hold our perspective still and respond in an automatic and habitual way. So when we do the number addition continuously, we fell in a habitual response. This is the mindfulness. Just an example. So in the last 2 decades, I use data from here. I think it's your colleague David Black developed it. So significant increase. Then you can see the achievement. So many achievement, but there's one thing, so lack lots of randomized design. So, but more and more study right now moving to this direction. So another achievement that we find lots of study using long-term, and long-term also has some issue, but it's valuable. And today we only focus on short-term. Just give you some ideas. So I want to share with you the central nervous system, CMS, represent our brain system, and autonomic system represent our body. So these two systems always interact. So to improve the health, also involved in the mindfulness and compassion. When we look at that part, our brain, our physiology, you find all connection, in particular sympathetic, parasympathetic. So they regulate our mood, our behavior, our attention. So the general question related to the field. So how does experience, including all the experience, shape brain network and drive behavior? So there are 3 questions we want to cover today, but this one, the last one, is our discussion. The conceptual framework I used, so about mindfulness, Also it share with the compassion practice. So there are 3 components. So basically try to improve the self-control, self-regulation. So for attention and self-control deficit control, so we find so many important things related to the attention, self-control, in particular here. Then if a person has a problem in self-control and attention deficit, in lots of behavior problem and mental disorder. So here we target improving attention self-control, then help our behavior and health. So for mindfulness, we all know involving attention. Also, we want to keep this awareness, acceptance state of our experience. We need self-control. So we can speculate this systematic training of attention and self-control is based on associated with brain regions related to the attention self-control network. So this is just an example. I give example about the design and the measures. So if we randomize the participant into 2 groups, so one group we use one form of mindfulness called integrated body-mind training. Originally, I didn't call it, just called a body-mind training. But in literature, reviewer, editor believe this method belongs to open monitoring mindfulness. Then we use relaxation training, just the one form of progressive muscle relaxation. So has been widely used in we know in the anxiety, in the mental disorder in the clinic. We also measure the attention, emotion, and brain response. So the first one, the 5-session, 20-minute session, we found improve attention. So this is the efficiency. It means shorter time means more efficient. So this is one aspect of attention called conflict resolution or exact attention. So, but we did not change the alerting, means sustained attention. So when we do the 20 session, we found it changed both. But some mindfulness only change this one. We change this one, but not significant. Some mindfulness change this one, they may relate to mindfulness techniques, so in my view. So the long-term RCT using other mindfulness program also show the similar result. You can see a different lab in the world. So except attention, we also find improved working memory, creativity, problem solving, and others. Like a recent study show, so the 10-hour mindfulness improve academic performance in students like literacy, math, second language learning. So the cognitive function or cognitive capacity is important also in the disease treatment. We can see so many psychiatric disorder are involving different part of cognitive impairment. So using the cognitive function, cognitive capacity to train the brain, it may help some disorder. Then we move to the second part of the attention, the emotion of the regulation of the second part of emotion regulation and the stress response. So certainly we all understand, so mindfulness can help because mindfulness asks practitioners to use non-judgmental and non-reactive way to the present experience. So stress is the same. Also stress response and emotion regulation are often interlinked. So we target this part. This is our data, 5-session, 20-minute session. So before, after, in the training group, mindfulness group, all the negative emotion reduced. Yeah, anxiety, anger, fatigue, but the positive energy, vigor increased. So there's another study replicate our method. So use the positive negative effect, show the similar IBMT versus RT group. So other study also show the similar result, like the present awareness on judgmental acceptance. So in mindfulness, so it's crucial in promoting the control. Yeah, the reason is that it increases sensitivity to affected cues. So far, many studies use a self-report, but we want to ask, can we use objective markers or physiological matters like stress hormone, cortisol, and the immune function? So there are studies like David Black and Rio Can also published paper about this topic. So we first use this design. So we use a 20-minute session, same design. We give the stress challenge for the participant. We measure the saliva, cortisol, and immune function, CA. So it's a basic part of the immunity. So then this is the procedure. So we measure here, after 5 sessions, we measure the pre-stress saliva, then stress, 3-minute stress period, we measure mental stress saliva after 20 minutes stress, because 20 minutes usually the stress go to the peak. So the post-stress after 20 minutes we collect saliva. Now we find, so the 5-session mindfulness can really reduce, this is a mindfulness IBMT, this is relaxation. So certainly reduced, but not change the baseline. Later we find change baseline need more session. So the after mental stress, we'll find the stress hormone increase, both group, right? If the weight least control go to even higher. However, you'll find that the mindfulness group slowly increased, but the relaxation groups significantly increased. The weight least go to here. So it means even though the 5-session mindfulness can help better manage stress, but cannot change the basal stress hormone. So if we change the stress hormone, we also can improve the immune function. So similar. So then we find the same situation, mindfulness improve the immune function, CA. And after mental stress increase, but you can see the acute stress can increase immune function shortly, but then turn down just within 20 minutes. However, mindfulness still increased immune function. So then we ask, how long does it take to change the baseline stress hormone and immune function? Because they will be important for the health benefit. So about 10 hours in total, we can spread. Like you practice 20 minutes, 30 minutes, you need 20 sessions. If you put it longer, you need a shorter session, we can change. So certainly dose-dependent fashion. And we all know this one. So the biological foundation for better health well-being, right? Okay, I found one person raise a hand. Maybe you can keep this question. Then let me complete that part. We have plenty of time for discussion. So emotion benefit and of mindfulness and compassion, I want to give a summarize here. So emotional dysfunction and stress harm bodies and brain health, right? Also get this consequence. So the self-reported improvement in emotion and the psychological well-being observed in our study and other study. So then you use the physiological index, you can also see the similar result. So enhanced psychological well-being and regulatory function actually critical for maintaining health. Importantly, foster compassionate behavior. But we find in our study, I didn't report today, so self-compassion seemed to happen first, then compassion to others later, from our method. So from now, we just complete some result, some study summary regarding to the behavior, including the attention, cognition, emotion, and also the physiology part, stress hormone and immune function. But from now, we are going to talk about the brain, how brain influences the physical, cognitive, mental health. So first is like attention and self-control network. Key message here. So the exact attention shared with the brain circuit of self-control, mainly in the ACC, anterior cingulate cortex, and the midline prefrontal cortex or medial prefrontal cortex. So then we ask one question or hypothesis. We hypothesize that, so if mindfulness can induce self-directed neuroplasticity, so we hypothesize it's possible, but we don't know when and how. So, but we believe, so the CNS, the brain, and ANS body may work together. So we first target our brain. So ask the first question. So does mindfulness change the resting state, our default network? We all know. So default network, resting state related to the negative emotion, because mind wandering is related to the negative emotion, published by a science article a couple of years ago. So there are others also show the mind wandering related to default network related to the negative consequence of health. So then we look at first about the resting brain. So it's a beautiful study. You can find, okay, in the midline, our resting state are all active during non-task. We do nothing, but the mind is heavily wandering, so we have a restless mind. So we call it resting, but actually it's a restless mind. So this is why it's very active. So can short mindfulness really change this pattern, can really reduce or calm down the brain activity, can save more resource. This is our hypothesis expectation. Then you look at the 5 session significant reduced activity globally. So only in the ventral ACC related to emotion regulation, autonomic control, and the PCC related to self-awareness. And here is the striatum inside related to reward, pleasant experience. We can see back, still very active, but then you, after 5 sessions, totally change, or change a lot. Then we ask a further question. So behavior change and brain structure. So we don't know when a mindfulness can change brain structure. If change, can bring changes related to behavior, such as emotion and other behavior. So we use another imaging method called MR diffusion tensor imaging to answer the question. Same RC design, but in general, this technique measures the diffusion of water molecule in a tissue. So in white matter, so we use a different like FA as the index, ADRD. You just remember, so the DTI has capacity to track the fiber change. So we find 5 hours, about 10 sessions, if we do the 30-minute session, really change the white matter structure. This is a bigger one. You can see the close to ventral ACC, self-control, dorsal ACC, cognitive control. Then also important, another important part called the corpus callosum. It's structure connecting 2 brain hemispheres. So can improve the emotional cognitive processing speed. So if we use the fiber track, you can see the fiber actually changed around the self-control center, go to the striatum, about the reward center, then go to some part about the self-awareness center. Then we do a correlation to see the emotion and the brain structure. We find a significant positive correlation. It means behavior change and brain change correlate with each other. So this is a summary. So the core brain regions involving the mindfulness training. So you can see among their part a lot. Some part about the PCC. Yeah, there is also in the insula. However, there are also others, like people find that the brainstem, found others. But this majority study actually cover, overlap, the finding overlap these regions. Then we can see the message for the compassion cultivation through mindfulness. So the recent meta-analysis indicate the key brain regions involving compassion also include similar regions overlapped with mindfulness. So this suggests that compassion cultivation can be done through mindfulness. Then the next part I want to mention the ANS and the CNS interaction. But I can see the same audience ask a question, Teresa. So real, should I answer the question because she raised hands twice, or should I just finish then I can answer all the questions?
I leave that to you. We will have time to answer them at the end, but if you want to take it now, go ahead.
Yeah,
you want to do now?
I have a plenty time, but Teresa, please keep a question in mind. Let me finish.
Okay, we'll definitely come to Teresa at the end.
Sure. So then we ask another question. So the brain change, behavior change. So if body and ANS and brain mind CNS work together to support mindfulness, or they need to separate, or separate work. So we don't know. So then we use the same RCT design. So we use the EEG, and we look at the literature. Actually, it's a review paper, wonderful review paper. So we can target a certain brain wave. Then we also measure physiology. Then like a skin conducting response. If the SCR is lower, means more parasympathetic activity. Heart rate variability, if the high frequency heart rate variability is higher, it represents more parasympathetic activity. So we use a 5-session, okay, what happened? We use a 5-session IBMT versus relaxation. So the blue one around here, cannot see, the blue one is the IBMT, this is a relaxation. So during the 30 minutes, we can see around the 15-20 minutes. So two training group all goes deeper, but mindfulness seems better or significant around here. Then we look at a high frequency HRV. We found a similar pattern about the 15-20 minutes. Two group achieve the peak state, but IBMT is better. Then we did the EEG midline, like ACC, theta wave, and high frequency HRV, parasympathetic, and the self-control. We found a positive correlate. So we can make a conclusion, at least based on our method. So the two systems, ANS and CNS, work together. So frontal midline theta power really correlate with high frequency heart rate variability to support or maintain the meditation state. So then we back to the compassion cultivation here. So we all know self-reported compassion questionnaire fail to show consistency from literature. However, studies suggest the heart rate variability is a potential objective biomarker for compassion. So if mindfulness go this way, so we assume the compassion cultivation can really benefit from heart rate variability change, or heart rate variability may be a good index. So for track the compassion cultivation, because the mindfulness study already show their pattern, but the compassion study, there are not many compassion study really focus on the physiology. So I think this is future direction actually. So far actually I focus on the healthy adults, not including in the children, not including in adolescent, not including aging population. But I want to show a study related to aging population, because aging population actually is a very good group who have commitment to continuously practice. So this is a longitudinal intervention in aging population. So we actually did a 10 years follow-up. So we measured the brain fMRI, we measured the physiology, we measured behavior. So for the brain, we measure the structure change, the functional change. So physiology, same, heart rate variability. Since we have two groups, one group is physical exercise, another is mindfulness. So we also measure the heart rate, baseline heart rate, and the respiration amplitude. So this for the functional connectivity. So we use the self-control center and the reward center to do the functional connectivity. So we find the IBMT group outperform PE group. So this is a subtraction. So it seems that the self-control plays an important role, but reward system also work with self-control, also important. So then we did a structure. I want to let you know, so this is related, call that putamen are part of the striatum, important part. So usually with aging, so all the brain structure, in particular this structure, becomes smaller in green matter. So we actually find a greater green matter in the IBMT group in here. So show some neuroplasticity in the aging brain. Then we look at the physiology change. Yeah, physiology change. So this is the IBMT is blue and the PE is red. So we use this one. So you can see a CMS, the 2 5-minute baseline around here, 5 minutes, and then in the middle 2 10 minutes state. So 10 minutes state means 20 minutes. It's a it's the 30 minutes session. So matters. Then you look at that part. It seems that for the skin conductance part, IBMT or mindfulness outperforms PE. Then we look at the heart rate variability, in particular high frequency. So we see the similar pattern. Higher means more parasympathetic activity. So supporting the more sympathetic activity following the mindfulness compared to physical exercise. Then we look at the physical exercise benefits, so heart rate, the chest, the respiration, amplitude, we call it BA. So certainly, so the heart rate, because the physical exercise group, they exercise the body, strengthen the cardiovascular system, so they have a lower baseline heart rate. Then they have a higher breath amplitude, chest respiration amplitude. It makes sense for the exercise practitioners. So then we do the immune function. Oh, I forgot the stress hormone, similar pattern, but lower in IBMT. However, for the SIG-A, the basic immune function, we find it seems that the IBMT is better. So even though before the stress change the baseline, also change all others. So this is also consistent with our study. So like 5 sessions in the young adults, this dose cannot change the baseline of cortisol and the immune function. However, they need a 20 session, at least 20 sessions, they can change the young adult. So this is many years. So certainly they change the baseline cortisol and baseline immune function. So then last part, we can look at the behavior. I only report the quality life. So it seems that the quality life also show that mindfulness is better than the physical exercise. So for this result, I have a question. I talked to my team. So we may use other different measures, maybe some indexed in PE can outperform IBMT or mindfulness. We don't know. But for the quality of life, WHO's quality of life, these scales, we found at least this part are significant, are better. So taken together, so I think for the healthy aging, number one, so our results actually indicate the mindfulness and the physical exercise function in part by different mechanisms, because from the behavior, from physiology, from the brain. The PE focus on the increase physical fitness, and mindfulness actually induce the plasticity, in particular in the striatum. But PE physical exercise also improve the gray matter in the hippocampus in some study. Of course, mindfulness also show the similar result. Then combining physical mental training may achieve better health and quality of life for diverse aging population, even prevent like Alzheimer's disease and related dementia. So my view is to combine, not just like only mindfulness or only physical exercise. So recently in the literature, actually, in the physical exercise literature, many researchers propose. So even though for the physical exercise can be done in a mindful way, so it means already combined some spirit, some attitude, some techniques. So there could be another new direction. So we have a new project. It's an NIA fund project. So we focus on a subjective cognitive decline. They call it SCD. It's interesting. So SCD, the patients or the people only report complain of like get a memory problem, cannot remember something easily, but they highly functioning. However, in the literature, they scan this SCD, the brain, they show the functional structure change, that is called a dysfunction, a functional structure deficit, overlap with MCI, mild cognitive impairment patients. So interesting, seeing that behaviorally, these people are normal, but in the brain level, they are not. How about the physiology? How about like the like a tau, like the beta? We don't know. So we actually, this project, we are focusing on this population, try to deliver the intervention, prevention, and also try to track the biomarker, if we can change the biomarker, and which biomarker is more sensitive for the intervention effects or benefit. Okay, so this, so far, I'm still talking about the healthy population. Then, right now, I'm going to move to the patient population. So first one, I'm going to talk about the substance users. Substance users like mindfulness, there are lots of studies. So you look at this, all the review paper. I didn't recruit more, and there are more papers actually. According to dual process model, the behavior change or behavior control has automatic and deliberative modes. So let me explain to you. So automatic means a habitual response. Deliberative mood means they exercise self-control. But we don't know which mood may change smoking behavior more effectively. So we choose the smoking behavior because it's really hard to change. And all the smokers know smoking is bad for health. They all know consequences, but they still do it. So interesting, in general, smokers need a strong motivation to quit in clinical, but over 90% smokers intend to quit, but often fail. You can look at a survey, national survey every year. So given that addiction or substance use are related to self-control deficit, so we hypothesize that the strengthening self-control could induce spontaneous behavior change in smoking. So yeah, in other words, we don't need to require the smokers to have a strong motivation to quit. But if we can strengthen self-control in smoker, we may change behavior, or may change behavior spontaneously. So my colleague argue when I want to do the study, they said it's impossible. It doesn't make any sense without the motivation. So this is after the publication, NIH report our study, but here's the design for you. So same design in smoker, non-smoker, using the 2-week, and the participant are college students, were not recruited for quitting smoking and did not have an intention to change behavior. So let me explain to you here, it's important. So the same RCT design in smoker, non-smokers, I think is fine. Then using 2 weeks of IBMT or RT, so people may argue, why not 4 weeks longer? So it's interesting because we actually ask a participant, so if they are willing to do 4 weeks, but some participants refuse, they said they cannot, then we find that they are smokers. So the smokers cannot tolerate 4 weeks. It means commitment, self-control, but non-smokers can. It's interesting. Then the participant, we recruit a participant from the college, from the whole campus, but we did not tell them we are going to ask them to quit smoking. We just ask if you feel you are interested in improving attention, then you can join us. You're welcome. Then if you are interested in stress reduction, then you can join in. So not any related to the smoking. Then we measure the subjective report like questionnaire. Then we measure the objective measures. We use the CO monitor. So they exhale, so we can see so how many CO level in their lung if they smoke. Okay, I think I may need to change the strategy because I found there are Teresa raised her hand again. So I'm going to answer a question right now, just in case people may want to know something, right? So Teresa, are you ready to ask a question?
Okay, let's give this a try. I'm not sure if Teresa raised again or if it just stayed raised, but we can call on Teresa. Let's see here. I'm going to try to give you the ability to ask your question, Teresa, okay? You should be able to talk now. Are you there, Teresa?
Okay, let me continue. If I don't know what happened here.
Yeah, I think her hand has just stayed raised.
Okay, got it. Okay, let me continue this part. Okay. So I will show you the result. So this is all the design. So participant actually did not know the study goal. They just participate because of they believe so the training may help attention and the stress reduction. We also did not tell the participant so the mindfulness or relaxation. We just tell them, so we have a training, we can help, or they may help the attention or stress reduction. That's it. So then we recruit a participant, they are randomly assigned to group. So this is a result after 5-hour 10 session. So the IBM group is the pre-post. You can see significant change. For the RT, there's one change, little bit change, but not significant. So we calculate about a 60% reduction, 30% quitting. Then we measure the brain because our hypothesis is that if the self-control deficit is related to the smoking behavior, so we should see the increased self-control regions activity, at least after training. So before training, smokers show reduced activity in the anterior cingulate cortex and PCC, midline PCC, compared to non-smoker. It means deficit in the self-control area network. Then after training, the smokers received IBMT, but not relaxation showed greater activity. You can see this one. So yeah, in other words, so the brain behavior, both brain behavior change. Then we propose this idea we call the spontaneous behavior change. So the two findings. So smokers are not aware of their behavior change. So in addition to one factor, so smoker did not know our goal, but we actually track all the participants, smoker, non-smoker, every participant, every session. So like we have 10 sessions, 30 minutes per session. So the participant report on questionnaire. So craving change or not, tobacco use or not. So we find some participants really change just because they from the CO monitor they change, but from the questionnaire they always say non-change. It seems that their self-report, subjective report, did not match the objective markers. So they are not aware of the change because consciously they believe they did not. But they look at their CO monitor. We even ask them to check their pocket. How many cigarettes left at the end of the day? Because our training happened in the evening. So they check the pocket, they realize their self-report is wrong, but the CO monitor is correct. And the tobacco left in their pocket is correct. So, so mindfulness actually induces some behavior change spontaneously and ameliorates the self-control deficit. So we propose an implicit change and unconscious change in addiction behavior. But this is just a few studies, so we need more. So our ongoing RCT just try to really explore the mechanism. So I want to make a point that we have a capacity for self-directed neuroplasticity, and it could change our behavior and habit. But I propose combining other methods, maybe more effective. So the current protocol we use neurofeedback plus mindfulness. Of course, neurofeedback plus RT, relaxation as a control. So far, I provide one example, substance use. I think in literature, there are lots of other examples and other studies. I want to show you one study here. I think these two are mental disorder, including addiction, depression, PTSD, pain. A very good review, cover all the mindfulness benefits, or some study including compassion practice. So in the mental disorder, in the problematic behavior. So I don't think I have enough time to talk about the depression, but I give you some idea and what we find. So depression often shows a deficit in self-control of attention and emotion. So longer time practiced have a positive effects on depression, already shown, using diverse mindfulness methods. But we want to ask one question: if the brief intervention, like 10 hours, can really change the symptom. So it's a little bit challenging. So then we run a pilot study to explore the efficacy in college students, but they are the first episode of depression. So we measure the self-control of attention and emotion. So we hypothesize that so the depressive students will show the deficit in self-control, at least in attention and emotion. So I want to show you the result first. So this is the result. So the similar situation like the healthy control and the depression group, you will find, okay, so the exact attention or conflict resolution show different. Longer time means low efficiency. So certainly depression population has attention deficit. This is the index of self-control of attention, right? Then after a 10-hour session, 10-hour intervention, so within the depression group, you find the pre-post, they all changed. So the more efficient after 10 hours, and also better sustained attention after 10 hours in depression population. Then we'll look at the emotion emotion part, you got a similar situation as we found before. Then we run the CBF, means the cerebral blood flow. So that time we want to measure the CBF. So in patient versus healthy control, before you find a global decrease. So this is consistent with the literature, global decrease in the CBF in certain brain regions, frontal, temporal, and others. So this is why the temporal, this is why depression patients show low activity and energy. They are not interested in many activity. So after intervention, so lots of positive. So they return, including the self-control center, the memory, emotion, others. So then we match with MR, we find that so the ACC is still important part of the, like a marker of the intervention of the mindfulness intervention in depression. So the summary first, we already found this part. The second part I will propose, even though I did lots of short-term training, but longitudinal full-scale RCT with a larger sample awareness. Yeah, it's important, even though we found something, but we cannot answer all the questions. The last point I want to make, the mindfulness may not fit everyone. Companion other method will work out. I just have some part of the future direction I have in mind. So number one, how to cultivate the mindfulness compassion effectively. So if we need to focus on both ANS and CNS, I mean the body and the brain, and how to deal with individual difference in both mindfulness and compassion. Like personality emotion can predict the benefit, the mindfulness benefit in the young adults is our study and other study. Also genetic factors like DRD4 also related to the experience. Then the epigenetic regulation or even the cultural social factors. So how to cultivate mindfulness compassion effectively is a big question. Yeah. So then another part is so gene and experience and brain interaction. So this is another question, maybe more. So we have 3 books related to some topic that's maybe helpful. Now I think I'm stop here. Thank you for your attention. So it's time. I think I can answer all the questions and you can comments and we can discuss.
Thank you so much. What a tour de force of so many studies, so much information you've given us. So we have some time now for questions and answers and discussion. A number of things have come up for me, but I want to turn to everyone else to start. Teresa clarified to me that it was an accidental raising of hands. So
yeah, because it would be very rude if I ignore any hands up. Yeah.
Right. One kind of just a question for clarification about making the information available for future. Are you okay with us presenting the to post the talk on our Center for Mindfulness Science as a past event? And then people are also asking if it's possible to have the slides as a PDF sent out, and if you're okay with that, you can send to us.
I can do that, but only one thing, I may need to talk to my team, so they may want to delay a few slides related to unpublished data or some patient information. If you allow me to do that, so I can share.
Yeah, whatever you need to take out, then you should do that. Thank you.
Sure.
And one kind of specific question was about the reaction time findings. This was kind of early on in your discussion. looking at the effect of IBMT on the ANT conflict domain. It was one of the studies you showed that was specifically on the conflict.
Sure.
That
Sure.
it was the question of whether the reaction time was greater related to IBMT after 20 sessions.
Yeah. Let me explain to you. So the ANT task, so it was developed by the Posner lab. So it's a little bit tricky part about the reaction time and the efficiency. So actually, we have two groups. The slides I show. One IBMT mindfulness group, another RT relaxation group. The two group. So the IBMT group show shorter reaction time, represent more efficiency. So this is the message I deliver. If you look at my slide after later I send you, you can look at it in detail. Yeah.
Thanks for that clarification. Another question, maybe a kind of overarching question that I'd like to present before some of these specifics that some of the community have posed is about the specifics of the IBMT intervention.
Yes.
And you know, you're quite aware in the mindfulness research community, there are some for many years now who have thought, you know, those effect sizes that you're reporting, there must be something fishy, must be something going on, and yet time after time you found similar findings, significant findings after just 5, 10, sometimes as much as 20 hours. So clearly there's something that is really changing the way people's brains are functioning and the way their attention is functioning on kind of detailed assessments of attentional function. So I think an understanding of the components of the IBMT instruction could be helpful. And then I think also what would be interesting to hear is, you know, the instruction, the detail of how the relaxation training group is structured, so that you can really understand the difference in what people are doing for those 10 or 20 hours and why these findings are coming up.
Sure. Actually, it's a good question, a very good question. So I didn't have time to introduce the IBMT component, the instruction in detail. So in the slides, I can add more about that part. I can add more. So when I send you slides, I didn't have time to talk because I want to leave at least 35 to 40 minutes so you can ask a question. This is why I shortened that part. So in IBMT number 1, so people still argue, what is mindfulness is? What it really is, people still argue, lots of questions. Now, what is compassion really is? So many definitions. But for me, actually, IBMT originally only called integrated body-mind training. So people think, oh, this is not mindfulness because your method has no mindfulness in name, in title. You are not. I think it's totally fine. So like Richard Davidson group, the paper they called my method IBMT as open monitoring mindfulness. So they think they belong to their part because they invite me to visit there. So we talk the question. So he realized, oh, this is part of open monitoring. So let me talk about the component. So the people, you often argue, okay, this technique is not mindfulness. Another technique is mindfulness. It's interesting. This is why really ask me, so talk more about the definition about the mindfulness. So people believe body scan is a mindfulness technique. Nobody argue, right? Body scan. So you need to scan your body. Let me ask one question. Can relaxation training include body scan? Because they relax a different part of the body, like a scan, right? Like a scan. Can you exclude awareness when they relax different part of the body? It's really hard, right? So this is number 1 question. So mindfulness is not involved in it cannot be defined as techniques, but instead a real mental process. So let me explain to you the process. So IBMT actually always focus on the body and the mind, two parts. So number one, we start from body. You know the Catherine Kerr from the Brown, she passed away. She had a great paper talking about the mindfulness start from body. The idea is very clear. So the, consistent with my idea, because I developed my IBMT in 1990s when I was a professor in medical school in China at the time. So we start from body because the body is really important. When our mind doesn't work, you cannot do mindfulness through mind process. You can pay attention to your body, right? So you can do shamatha. So you do the body awareness. So we start from body. So how to start that? So we ask people to go back to their body. So they have a little bit of posture, very simple posture. The posture means they need to be aware the body is moving, body is stand up, body is sitting down. Then at the same time, ask them to try to relax the body. So their part is exactly overlapping with relaxation training. Relaxation training will follow the exact protocol about progressive muscle relaxation. You can find on the website all that part, because our relaxation training trainer is a good instructor who deliver the RT in the clinic. So follow that part. So let's see. So if relaxation component overlap, right? Then when people close their eyes, they have a mental imagery, right? We have a mental imagery, of course, mental imagery. So relaxation training involves lots of mental imagery. They feel warm, heaviness, right? However, in mindfulness field, many people argue mental imagery is not a mindfulness techniques. You can ask some people, but some people think it is. I want to bring out one example for the compassion training. Compassion mindfulness or compassion meditation is a part of the Buddhist tradition, right? So compassion training really need you to hold a mental imagery. Then you want to send a loving kindness, right? It's a mental imagery. So in IBMT, we have a little bit of guided mental imagery just because we have so many mind wandering. We want to guide them to go to a little bit of focus, but we don't push them to control them to do the mental imagery. So that's why in the instruction, I give the instruction. So don't try to control your thought. Don't try to control. Then people say, okay, don't try to control. It means I don't need to do anything. I just stay there. Yeah, you're right. You stay there with your body awareness. You stay there with your mental state naturally. That's it. But then we find the issue when you want to deliver the message to teach the experiential practitioner. So the people have lots of experience with mindfulness. When you want to deliver this idea, usually got a resistance. They say, no, this is not mindfulness. No, this is not compassion. We got a problem. But when we work with the novice, the college student, they participate in study only for the money. They don't care. They never look at it online, the paper, the book, the video. They just follow instruction. They get in simply because non-occupied mindset, non-expectation, nothing. It's easy. So I found when your body is ready, you little bit push your mind, then you are in the zone. But in the zone, important thing is to keep the awareness gently. So I use a term called restful. You need to be restful first. Then you go to a little bit of alertness, awareness. That's it. But for the whole instruction, actually I'm working on the book. So try to get instruction, but I try to manualize this method. I train some postdoc to do that, but I found that the change direction, it become not organic. It becomes something dry. So I found that the trainer actually played an important role in the effect, because trainer can really control the quality of training. A trainer can really figure out the acceptance. If the participant really get a real message, really follow instruction to do the quality of practice each session. So for the short-term training, we actually need to really influence their learning path. If you cannot influence their learning path, cannot influence their quality of practice, then we get nothing. This is why I train somebody, so they just follow the manual, deliver the technique, didn't work out. So this is why 10 years ago in our paper, we proposed trainer could be the active ingredient in the training effect. So I hope, really, I can answer your question, but it's a long question. Yeah.
And I think your answer overlaps with a growing awareness now, even some recent publications in the field. You're probably also aware, looking at the other MBIs, mindfulness-based interventions, and showing exactly that intuition that so many of us have had over the years, that it is being borne out with the trainer effect. And, you know, as you're also probably aware, within these MBSR, MBACT teacher training communities, there's been a long-standing, it's a kind of argument within the teaching community around, well, how much formal training and consistent personal practice are we going to require people to at least self-endorse? It's impossible to know for sure they're telling the truth, in order to say, okay, you now have the ability to do these trainings. So it gets, I think, you get very much into one of the aspects of mindfulness training that is most difficult for the long-term kind of replicability, kind of challenge for the field. If a lot of what is being conveyed through the trainer, then it really requires some unpacking of what is it about the trainer, and how much of that can be conveyed via an app or instructions that are being pre-recorded and played over people's phones, or through some interaction with a robot or what have you. As you know, these are things that are now coming out. I guess one follow-up on that is, have you also had the experience of trying some of these disembodied ways of teaching IBMT via apps or just recordings that people do on their own at home? And what have you found with that?
Yeah, good question. Actually, we tried online training. Interesting. For the online training, important thing is the real interaction. The real interaction can really engage participant, not the recording. If the recording is online, to ask a participant to do by their own, usually they will lose the engaging component. We find it will not work. So on the Zoom session, when our trainer deliver training just in person, every session they present, they have interaction, the result shows significance compared to recording you do by your own. It's fit the literature, right? We have a recent study, I think published last year and this year. So we do the neurochemical change in the brain. It's the totally on Zoom training, Zoom session. So we have interaction, trainer interaction. So we found the similar pattern as the on-site in-person training, but the trainer really need to qualify, they really need to interact with the participant, just online. So there's another group study in University of Washington you may be aware of. It's the infant study. So the infant study, so infant less than 7 months, so you present as many as possible language possible, they can learn. Like a super learning machine. But from a mother tongue, that you record with a machine, then the infant cannot learn. So it's interesting, it's published about 15 years ago. That show the human interaction, real interaction can really change our brain physiology behavior.
Yeah. There's something also, I think, about the tone of voice that we still don't understand that is probably really essential there.
It's a good point. Yeah, we found this too, yeah.
So a few questions that kind of relate to that.
Yeah.
One is, what are the range of effect sizes that you've seen in your different studies?
Yes,
And
we did.
how long do the effects persist or shift related to any longer term follow-up? And I guess that's also related to you presented some data which I wasn't as familiar with, people in the healthy aging who they had been doing IBMT type practices. Was it more for months or years as opposed to the shorter term interventions?
The aging study is 10 years follow-up, 10 years in the community. Yeah. We failed in American community, but we succeed in Chinese community. The 10 years, so they follow. So you ask the lasting effect, right?
Yeah, and the range of effect sizes.
Yeah, your effect size. So number one, I can answer the effect size first. So recent years, like the past 5 to 7 years. So from the past 7 years, we did a lot of effect size calculation. It's interesting. It depends on what kind of matters, the behavior matters or the physiology matters or brain matters. So I explain to you for different part. So number one, for behavior level, the matters. So the effect size, usually around the medium size effect size, is our study. So for the physiology and the brain, physiology means the heart rate variability or the cortisol immune function. The brain means the connectivity in the brain function or structure change, a white matter change, a gray matter change. So for the physiology and the brain change, we find it's medium to large. It depends on which study, which population. Yeah. Then for the lasting effect, it's a very good question. For lasting effect, we found lasting effect is really sensitive to the age. This is a new thing we learn. Interesting. So for the college student, for the adults, because they have a diverse environment every day, right? They're busy. So if they only practice 5 sessions, the effects can only last about a month, depends on the person. If you go to 10 sessions, 20 sessions, 10 sessions means about 5 hours in total already. It means quality of practice. Not just they say, okay, I did 10 sessions. No, quality we observe. Then go to 20 sessions. So they can last about 3 months or even longer for some people. Then they can go to even longer. But for the young adults, we did not succeed in recruit them to motivate them to do over like 3 months, 6 months, because in the school they have a semester, they graduate. So many things, it doesn't work out. Then we do the children. That we found, even longer. A children's study, we had a 10-hour session over 20 days, similar as our brain study, physiology study. So they actually last 18 months. About 20 sessions, 10 hours in total, they over 18 months. So we ask teachers, ask parents, then we realize that young children, actually, they have a relatively simple environment, social, physical environment, not so many stressful situations, not many from work, life, relationship. So they carry over longer. If you look at development psychological study, you find, there's something. So this is why I proposed brain, environment, experience, and the gene. They got a very complicated situation. So I hope I answer your 2 questions.
Yeah, for sure. It sounds that data would suggest that this movement to try to bring mindfulness training into childhood and educational environments on a wider spread level would be really yield benefits that may be greater than what can be done if waiting until people are in their early adulthood before they really are exposed to this kind of mental training.
One thing relatedly, I just add one thing. Our population is about 5 years old. So my study did not follow like the adolescent. So adolescent, I think is their social brain is still in developing. So they may be more sensitive to environmental change. So I don't know if it will work out for them better. But if they're sensitive to the environment, so they are more open to the experience. They just one thing, commitment, how to do the commitment. For the young children in our group, actually, when we deliver the message smartly, they just accept. I think this factor maybe should consider. Yeah.
Yeah. And Ali C was asking about the size of the study with the smoking cessation, or the impact. Sounds like it was you were actually assessing non-intentional impact on smoking behaviors, a 60% decrease. And with the same study related to the question of the sample number, you showed there the impact on increases in anterior cingulate cortex activation, and I believe that was fMRI finding.
Yes.
And I'm curious to know, and I'm sure you probably have a nuanced answer about this, but when you see these ACC findings, are they usually by contrasting the resting state T2 sequence, or what kind of sequence, I guess is the question, before and after, or is it comparing two states, like a meditation state versus a cognitive engagement state before, and then contrasting that with the same two states after, or where it is that you see that contrast of an increase of ACC activity?
Yeah, it's resting. It's resting, not the meditation, non-meditation. It's totally resting. So two group resting. We also not only use resting, we also use another two new measures, like some fractional low frequency amplitude some way, some new method. So we try can really target the both signal change, total resting. But if you ask the sample size, that's why we have ongoing RCT. We want to complete study using a larger sample. So even though I think our pilot study, we use 20 versus 20 in two groups, and we got, I think, usable data around 15 each group, usable data. So for the larger RCT, we target 240 in 5 years, 240. So that study I discussed a lot with people. I think it's a pilot study, shows some promising result, but we cannot conclude. So if we can amplify to all the population, because a smoker can have a lot of different status situation. Yeah, but we just want to emphasize if motivation is so important or not. From my point of view, I talked to the motivation science researchers. So they said motivation is certainly important, but motivation is not the only thing that can drive behavior change. I think I agree. So we have a motivation. I have a motivation, strong motivation doesn't mean I can become a president, right? Motivation is one factor. There are lots of factors. So we propose another factor, self-control, another factor, but reward also another factor. We don't know. So
yeah,
that study, yeah.
David Black is bringing up a question, and it's also related. David and I and some other folks in the center have been putting together some grants to really study something somewhat similar to what you're looking at with that smoking study and college age substance abusing population. And his question is, can you elaborate further about how mindfulness may bypass motivation in smoking cessation in your dual process model? It seems to have implications for revising classic behavioral change models.
So let me reframe your question. So David want to ask if the mindfulness, how mindfulness works in the dual process model,
right,
under this
how
framework.
Bypass motivation. Yeah.
It means it's a big question. Yeah. So does mindfulness have so impact result, so impactful? So personally, I think this is why I propose that mindfulness is one way to change behavior, because people differ a lot. Yeah, some people may benefit from physical exercise or video game or others, right? Not only mindfulness. Okay, let me look at answer this question. So right now, so let's see two dual process model, one conscious, one unconscious, right? So for the conscious level, there are so many studies. So mindfulness also emphasizes the conscious control, right? Awareness. So I think plenty of studies support mindfulness really help. Even mindfulness may improve some kind of motivation, right? You look at some study. So, but I'm going to focus on unconscious regulation, another implicit pathway. So I think mindfulness actually is a conditioning process in my personal experience. Let's see, you look at it, you observe your thought, observe your emotion, sensation, you condition this status, right? You condition. Then conditioning can really influence the habit. The momentary you find out change, you track. Momentary you find a change, you track. So implicitly, mindfulness is an effective conditioning strategy or techniques, in my understanding. So, however, how to make mindfulness more powerful in the implicit process and explicit process. So this is my interest. So my teachers, I had several teachers, my teachers actually trained me in a different way. This is why I proposed the body. We use the term bodyfulness versus the mindfulness. The beginning, I have a bodyfulness. I was so excited. I think, okay, maybe number one who had this term. Then I realized, no, there are so many smart people out in the world that might be on the Google. Then I search Google, oh, bodyfulness, are they there? It's a different meaning from my understanding. Yeah. So the bodyfulness I found can really trigger the implicit process through autonomic control. This is important. So this is related to mindfulness strategy. So many people practice mindfulness. Implicitly, they use a control strategy. They are not aware. They have expectation, they use control. They are not aware. So in their part, they really stop or limit their progress. This is the important part. I'm not sure if I answer, but I cannot occupy too many time for one question.
Right.
I realize, yeah.
I think you went a long way towards answering, so thank you. And because of time, we'll have to wrap up with that. But this was very helpful to have this time for question and answer as well. And I just thank you on behalf of our whole community for being with us today and for all the wonderful work you've been doing over the years and continue to do. Looking forward to seeing the results of your current work. And for those who may be joining in for our next couple of talks, we have one on May 10th and another May 25th. Peter Malinowski from the UK, speaking on attention and metacognition and his work with EEG studies in mindfulness in the United Kingdom, and then Judd Brewer speaking, who's now at Brown, and you saw some references from Dr. Tang on Judd Brewer's work. So look forward to next time, and thanks again, Dr. Tang, for being with us.
Oh, thank you for the invitation. Thank you. Bye-bye.
Bye, everyone.